Hello, I am Melissa Silva, the Executive Director of Louisiana Mental Health Association. Welcome to our Behavior Health Around the State educational series. LAMHA collaborates with our partners around the 10 regions of the state, all of which share similar missions to us. We're offering this series aimed at bringing attention to and education on key mental and behavior issues and initiatives affecting our individual communities. This year's Behavior Health Around the State series focuses on such topics as suicide prevention, youth mental health, gambling and substance use, intellectual disabilities, and developmental disabilities, LGBTQ+, and maternal mental health. We are very excited to bring experts from our local communities and from around our state to provide current and relevant information on these issues. In our fourth year, we are continuing to offer these educational series through our long-term partnership and support with the Office of Behavioral Health.
Hi, everyone. My name is Todd Cirillo. I'm a trauma therapist here in Jefferson Parish, and I'm also here with Marti Tidwell, another therapist in Jefferson Parish. And we're going to talk about children's mental health, some of the prevalent issues that the kids face, some interventions, and then some resources. And the focus really is on Jefferson Parish here today. Mental health is a balance between the mind and the body. That's the simplest definition, and I think the easiest definition that encompasses all of what people go through. Specifically, we're going to talk about children, and it's usually easy to pick up on when there is the kids are out of balance, their mind and body. So common mental health issues that children face are anxiety, depression, and post-traumatic stress disorder, PTSD. And we found that because in working with Jefferson Parish School District, they surveyed some of the high schoolers, and anxiety and depression are the two items that the students themselves felt that their peers and themselves have really been experiencing. So we decided to focus on anxiety, depression, and post-traumatic stress disorder due to the high rate of community violence, interpersonal violence, meaning domestic violence, physical violence that the kids are facing in Jefferson Parish. 1 in 6 children ages 2 to 8 has a mental health or behavioral or developmental disorder. And that's a lot. So if you think about that in terms of the classrooms, then it really puts it into perspective about why this is so necessary as a focus to find interventions, ways to identify, intervene, and resources that can be provided for the kids. These are some statistics about the prevalence of mental health disorders. And really, the important one is the 22.2% of adolescents that have mental health disorders were classified as exhibiting severe impairment or distress. And then you see it's further broken down with between mood disorders, anxiety disorders, and then behavioral disorders. And this is what we're seeing, especially in the schools. It's important to remember that everyone experiences anxiety and depression throughout their lives. It's a normal part of life, and both affect each person to varying degrees. Usually, when we hear about anxiety or we hear about depression, we think of only the extreme versions of it, when they affect our daily functioning and our ability to cope. Because throughout all the definitions of anxiety, depression, and even PTSD, that one part about our ability to cope, how it overwhelms our coping capacities, that's pretty much a common throughout all of those mental health issues. And in the brain, we think of terms in regulation versus dysregulation. So we have the learning brain, which is a state of safety and comfort. That's the prefrontal cortex. That's where all logic, all reason, all language and time, sense of time lives. That's our rational brain, sort of the upstairs brain, they call it. And then there's the survival brain, which is a state of fear. And this is where the amygdala kicks in. That's our body's natural alarm system. And that's what gets us ready for fight, flight, or freeze. It's down in the brain stem. It's the oldest part of the brain. Language does not live there. Sense of time does not exist in the brain stem. Rationality does not exist. It is only there for the function of getting us ready to fight, flight, or freeze. And it's a necessary part of the brain. It's a necessary part that has kept us alive and tries to keep us alive, but it only functions fight, flight, or freeze. And remember that the brain is organized to act and feel before it thinks. And that's important to remember, because a lot of the times when we are trying to regulate a child, especially, more often than not, we ask them repeatedly to tell us what is wrong. When, if they are in that survival brain, the brain stem, they cannot access the language part of their brain to provide us with a narrative. They're only in acting and feeling. And so we want to respond in such a way that we can help regulate them, to relate to them, and then we can reason with them. So what is anxiety? Anxiety is more internal than external. It's essentially the fear of the unknown, something out of our control. And it has a lot of catastrophic thinking, the worst that could possibly happen. That's what the brain then focuses on. Anxiety differs from fear because fear usually is something that can be focused on, it can be dealt with, and fear we can sort of let go. Anxiety, again, is just, we don't really know what's wrong. We don't really know, we can't alter something physically with it. It's sort of like grabbing at fog. But it affects us, our entire being. It affects us physiologically. We begin to get, our heart goes, we might begin to sweat. Behaviorally, it causes that catastrophic thinking and almost leads to a panic attack. Or psychologically, in our brain, all we can think of is the worst possible thing that can happen. I'm having a heart attack. I will never get this chance again. Everyone is looking at me. Whatever might be looping through our brains. And it can be mild to severe, such as that's where the panic attack comes in. And the panic attacks give off that feeling physiologically that we're having a heart attack or something is horribly, horribly wrong with us. And panic attacks can be dealt with, and we'll get into some of that later, but they can be dealt with, especially the peak of a panic attack really can only last about 12 to 16 minutes. And part of the grounding exercises that we'll get into later will elaborate on that, of how to get our mind focused on moving through it. So children with anxiety, they may appear more clingy than normal, especially the younger ones. They might be more restless and fidgety. Again, with the younger ones, complain of stomach aches or headaches. They're going to have a psychosomatic response. Display changes in their daily eating and especially their sleeping habits. You always want to pay attention to your sleep habits. That is one of the best indicators to if we're in balance, our mind and body is in balance, or if we are out of balance. They're going to express negative thoughts and worries and get upset or angry, more frustrated a lot quicker, a lot easily. They're going to have a short fuse, have bouts of unexplained crying, or struggle to concentrate. And we want to remember, again, that anxiety is normal. Like good anxiety while studying for an exam or before a game, that's called motivational anxiety. And that is good. It is helpful to get someone ready and even focused occasionally. And then there's social anxiety, which is not wanting to go out in public, see friends, or take part in activities. And this is really a lot of what the students are facing right now. A social shyness is normal for some kids, and especially teenagers. Where it becomes an issue of social anxiety disorder is when everyday activities, shopping, speaking on the phone, they cause intense and overwhelming fear. And again, it's usually the fear of the unknown or the catastrophic thinking, such as they're going to say something wrong. They're going to, whatever happens is going to be humiliating to them. And it tends to affect the older children who have already gone through puberty. So what are some actions to take for anxiety? Well, anxiety works usually like a escalation cycle where it builds and then it peaks and then it comes down. So when we begin to feel that anxiety, that feeling in us, a tenseness, could be the headache, could be a nervousness, we start moving our hands or tapping our feet. We want to acknowledge that anxiety, recognize it. Say to yourself, a lot of self-talk is extremely important for anxiety. Okay, now I'm feeling this way. My heart is beating fast. I am okay. And then you want to focus on like where your feet are, where your hands are, your surrounding. You want to observe rather than react. So observe the bodily sensations of anxiety. Move your body if that helps. Sometimes going for a walk or getting up. Sometimes you have to, try to lay down or just sit quietly, but oftentimes that moving around tends to help because all anxiety, all sadness, all anger, it lives inside of our bodies and we have to get it out in an appropriate way. This is where grounding techniques come in, but we also want to tell ourselves with that positive self-talk, this is normal and it's temporary and it will pass. So some coping strategies, especially for anxiety, some of this can work for the depression and the post-traumatic stress disorder as well, but some of the coping strategies are very simple. And we look towards these very simple exercises that can be done usually without much extra stuff needed, can be done almost anywhere. Hand exercises, they're like brain gym movements. So it can be as simple as putting your hands together and then just moving your fingers. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. It can be something as simple as, again, just like this. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. It can be moving your hands just simply back and forth. And of doing one, can put them like this. One goes up, one goes down. Very, very simple, but that focuses the brain or refocuses the brain from the catastrophic thinking to what's happening with one's hands. Again, 1, 2, 1, 2, 1, 2. Very simple hand exercises. Another really good exercise that's very simple is just get a piece of paper, but you don't even need to do it on a piece of paper, and you draw an infinity symbol, which looks just like this. And the important thing with that is you just continue to trace it over and over and over, because rhythm is regulating and it creates a rhythmic movement And you just continue to go over and over and over because rhythm is regulating. And what's nice about the infinity symbol is you can do it even on someone can do it with their finger, on their hand, or on their arm. You can do it almost anywhere, but that again, rhythm is regulating. So it refocuses the brain to sort of get us out of that catastrophic looping that the brain can do during an anxiety attack. There's progressive muscle relaxation, which is really good. And that can be something as simple as making sure your feet are flat on the ground. You can focus on tightening up your feet and then your legs and progressively going up the body. Or you can do something as simple as just putting all of that anxiety into your hands, or all that sadness, or it could even be for depression, but like into your hands, and you squeeze as hard as you can. Take a deep breath in, deep breath out, squeeze, 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 and then fully open one's hands. Then you do it again. Squeeze, squeeze, squeeze as hard as you can, and then open up. And with that, you want to notice how it feels from going from very, very tight to opening your hands. You want to know how the muscles feel in your forearms. You want to say to yourself, I feel my muscles getting very tight and relaxing, getting very tight and relaxing. Grounding exercises, Marti will go into that in a little bit. Mindfulness, yoga, positive self-affirmations, walks, things like that. And then emotional freedom technique and tapping is based on energy psychology, but essentially it is finding meridian lines in the body to use a certain amount of tapping that helps release the, say, blocked energy. And the easiest one for tapping would be like butterfly taps. You can do it with two hands right below the collarbone. You can do it with two hands and you just gently tap, but strong enough that you feel it. And that helps with anxiety and depression too. Or you could do it with one hand or one on each side, like that. And that's tapping. And that helps as well. Right below the collarbone is very, very good. Right above your eye or on the side of the eye is very good as well. And so that's some coping strategies, primarily for anxiety, but they'll help with the other ones as well. So depression, what is it? Clinical depression means that you must have a depressed mood for over 2 weeks. You have to have a loss of interest or pleasure in things that normally brought you pleasure and interest, and it's a noticeable change from how you were, meaning that others notice this, they pick up on it. And a true depressed mood is really not getting out of bed for those couple of weeks, not doing anything you like to do. A lot of times with the adolescents, they'll say that they're depressed, but they're still playing their video games, they're still texting friends. That's really not true depressed, clinical depression, because true clinical depression is all day, every day. It affects your sleep. You might have profound feelings of guilt or worthlessness, and you have nothing really to base that upon. And there's an inability to concentrate as well. So some of the big signs of depression, again, sadness, and they don't even have to be uncontrollably crying all the time, but it's their whole entire presence, their being is just down. Makes it very difficult to see any bright spots in anything, no matter how many things you put towards the individual. things that they would normally like to do, again, they're not responding to it. There's appetite changes. They might have suicidal thoughts or thoughts of harming themselves. They are withdrawing from their social life. If they played sports, they might not want to anymore. If they were in band, might not want to go to band practice anymore, things like that. They will not hang out with their friends as often. They're going to have trouble sleeping. That's another one. Irritability, and just looks like they have a lot less energy than they used to have. Again, these are signs that people on the outside can witness with somebody who has possible depression. So what are some interventions? Cognitive behavioral therapy, or CBT, is really a big one for treating someone with depression. So a therapist would utilize cognitive behavioral therapy, and this helps people to identify and change destructive or disturbing thought patterns that have a negative influence on their behaviors and their emotions. And essentially, what CBT is it teaches someone that our thoughts control how we feel, controls how our body reacts, controls how we behave. And in the simplest form of it, especially that's what I use with the little ones, is if you think good, you feel good. So CBT trains a person to change the negative thought into a more tolerable thought. And that in and of itself will change how the person feels, will change how their body reacts. Because remember, they might have headaches or stomach aches, very tense. That'll help release some of that. And then it changes how they behave. There's acceptance and commitment therapy, ACT. And this is an action-oriented approach in which clients learn to stop avoiding or denying the intense emotions, but instead begin to accept them as appropriate responses to certain situations. So it's not accepting everything that happens, but it is attaching it to the certain situations that may be causing the depression. And then there's self-esteem building, which is extremely important because remember, with depression, that's where the feelings of worthlessness comes in. And that counters that. Self-esteem building counters those feelings of worthlessness. So what's post-traumatic stress disorder, PTSD? We hear about it a lot. And a lot of times we think that it comes with people that have been through war. And it's true that it began there all the way back. There's been different titles for it all the way back from pre-World War I. But now it's pretty much post-traumatic stress disorder. And instead of just applying to veterans or people that have experienced horrors of war, what they found is that the traumas that people experience can cause potential post-traumatic stress disorder in people that it's not exclusive just to veterans anymore. And it's a psychiatric disorder that may occur in people who have experienced or witnessed a traumatic event or a series of events or a set of circumstances. And an individual may experience this as emotionally or physically harmful or life-threatening and may affect the mental, physical, social, or spiritual well-being. And symptoms must last more than a month. So it's normal to have some of these symptoms after, say, a car accident or a carjacking or community violence or a death. But what therapists will look for is if those symptoms remain after 30 days. And this can be anything from, like I said, a community violence episode, carjacking, it could be a death. Any of those, even if we just hear about it from someone that we care about or love, that can lead to a possible diagnosis of post-traumatic stress disorder, which is very treatable as well. And so what are some symptoms? The most common symptoms occur in these four categories. One is intrusion, and this is the one I think most of us have heard about. So intrusion means intrusive thoughts. These are like flashbacks. That's what we hear usually about the war, or about if somebody is the victim of violence. So there's the flashbacks, physical violence, sexual violence, domestic violence, threats. So they get into the dreams as well. We have distressing dreams, but mainly it's the flashbacks that we see and hear, especially if we get triggered by something that reminds us, or at least reminds our brains of the event. Then we have those intrusive thoughts. Then there's avoidance. So avoidance can sometimes be a helpful coping strategy, and other times it can be a harmful one. Like in this case, avoidance is trying to stay away from all reminders, all and any reminders of the trauma. And so people will go to great lengths to just simply avoid, like if something happened on a certain street, never driving down that street again, even though it's the closest to our house or something like that. Not going around people that may have some type of experience as well with the trauma. So it's really, it's a extreme avoidance. Then there's alterations in cognition and mood, meaning that we have some negative thoughts or beliefs. We're blaming ourselves for the trauma. We are thinking that we will never get over it. We have distorted thinking of, well, if I had just done this, then this would have happened, or this would have never happened. If I just would have turned left, then this would have never happened. And then we have changes in arousal and reactivity. So this is where we become hyper vigilant. We're always on the lookout for unsafe situations. It affects our daily functioning and concentration and sleeping. We're easily startled. We're always on edge, which can cause a lot of irritability as well. But we're always on edge. And it's that changes in arousal and reactivity that we're always looking for an unsafe situation, environment, person. And just a quick statistics here about child protection services in the US. Get around 3 million reports each year involving about 5.5 million children. Proof of abuse in about 30%. Types of abuse, 65% neglect, 18% physical abuse, 10% sexual, 7% psychological abuse. All of those can lead to anxiety, depression, PTSD. 3 to 10 million children witness family violence, and 40 to 60% of those cases involve physical abuse. Children and teens have PTSD if they've lived through an event that could have caused them or someone else to be killed or badly hurt, such as sexual or physical abuse, violent crimes, disasters such as floods, storms, school shootings, car crashes, fires may also cause PTSD. And other events that can cause it are war, a friend's suicide, or family member suicide, or seeing violence in the area that they live. And that is it for now. And now the amazing Marti Tidwell will take over.
Hi, good morning. Thank you so much, Todd. And yeah, I'll go ahead and get started on my part. So I'm gonna kind of pick up where Todd left off, just kind of talking about interventions for PTSD and working with kids. So these are kind of some of the evidence-based treatments for PTSD working with kids. So the first thing I'm going to talk about is TFCBT, or trauma-focused cognitive behavioral therapy. So trauma-focused cognitive behavioral therapy is an evidence-based treatment model designed to assist children and adolescents and their families in overcoming the negative effects of a traumatic experience. And there's kind of different variations of this. The two that I am trained in are the youth PTSD model, or the YPT, and then the preschool PTSD model, or PPT. So the YPT is used for older children, I think ages like around 6 or 7 to teenager, and then the PPT is used with younger children, 3 to 7, 3 to 6, 3 to 7. And then we also have eye movement desensitization reprocessing, or EMDR. This is a structured therapy that encourages the patient to focus on a traumatic memory while experiencing bilateral eye movement stimulation. So there's different ways of doing this. Most commonly, it's used just with hand movements, and having the patient talk about and focus on the traumatic memory while doing the bilateral eye movement stimulation. Another one is the grief and trauma intervention, or GTI. This is designed for children with post-traumatic stress due to either witnessing or being the direct victim of violence, disaster, or also witnessing the death of a loved one. It's commonly used with children who've had the death of a loved one, or witnessed some sort of community violence, or been victim to community violence. So I'm going to talk a bit about grounding techniques now. So in addition to, and really with all of these different sorts of interventions, grounding techniques are really an integral part of that, because we know that re-experiencing is one of the things that happens a lot with PTSD, and with kids that can come in the form of nightmares, traumatic flashbacks, panic attacks, and then intense or strong emotions like anger, shame, guilt, despair. And with younger children too, it even can look like tantrums and things like that. It can come across as angry outbursts. So grounding techniques are really important to kind of help a child be able to regain some sense of safety, and be able to kind of get out of that traumatic memory and be back in the present moment. And I know Todd had talked earlier too about the brain and kind of what happens with the brain with trauma. And so one of the things that we know happens with the brain is that it's almost like the brain gets flooded with all of these stress hormones, and kind of the higher functioning parts of the brain, prefrontal cortex, kind of shut down, and they go into that survival mode, that fight, flight, or freeze. And so grounding techniques are really important to help bring them back to a place of balance, and where the higher functioning parts of the brain can come back online. Okay, so we have several different grounding techniques here. There are visualizations, and with visualizations, you really want to try to include all of the 5 senses, help them reconnect to all 5 senses, sight, hearing, touch, taste, and have them be able to kind of reconnect with like a happy memory or a safe place. And then try to, once they're able to focus on that happy memory or safe place, think about like, okay, what do I see in this place? You would have, basically, you would have them, you know, close their eyes, take a few deep breaths, and then really try to focus on details about that safe place or happy place. So you would say, you know, what do you see? What do you see in this place? If it's a beach, you know, can you see the color of the water? You know, what do you hear? Do you hear the waves crashing? Do you hear birds flying overhead? What do you feel? So can you feel like the sand under your feet? You feel the warmth of the sun, the coolness of the water. There any tastes? Maybe it's something cool to drink. Do you have, or what do you smell? Do you smell like that salt water, or kind of just that like fresh kind of beach air? And then just have them focus on that for a moment. Take a few deep breaths, and then, you know, once they're feeling calmer, then they return back to the present. And then there's lots of different mindfulness techniques out there. And again, mindfulness is just about, it's getting out of the traumatic memory and returning back to the present. And there's lots of great apps out there as well that have different mindfulness techniques for kids, as well as the visualization techniques. And then during a panic attack or flashback, traumatic flashback, your emotions can take over your thoughts and physical responses. So again, that's why grounding is important, because it helps to interrupt the body's response and return your brain and feelings to a place of safety. That's kind of the goal in the moment. So some other grounding techniques, some of the ones that I really like are the 5, 4, 3, 2, 1. So again, you would have the child just take some deep breaths and then look around and name 5 things that they can see around them. So look around the physical space and name 5 things that you can see. So I see the pictures on the wall. I see the couch. I see the table. 4 things that you can feel, that you can touch, and you have them say it out loud. You know, I actually feel, you know, I feel my feet on the floor. I feel my sweater. I feel the chair beneath me. So things like that. 3 things that you can hear in the present moment. So, you know, maybe I can hear the air conditioner. I can hear your voice. I can hear the car driving by. 2 things you can smell. So they might, you know, say like, I can smell my sweater, or another kind of thing that I like to suggest for kids is to have sometimes like a piece of cloth or an object that kind of has a scent on it that is calming and grounding to them. So you can use like essential oils like lavender oil or something like that. Or maybe they have like an object like a blanket or something like that that like smells like their mom or smells like home in some way. They can kind of have with them and smell that, and that can kind of help as well. If you're in the moment and you don't have anything that you can smell, you could have them say, okay, what are 2 smells that you really like? What are 2 smells that are calming or relaxing to you? And then one thing they can taste. So again, it could be like, could be taking a drink of water, like putting a mint in their mouth or chewing gum, or if they don't have anything, they can think of a taste that they really like. Another grounding technique that is great is having the child like name categories of things. So, you know, you could say like musical artists, sports teams, actors, cereal brands. How many Marvel movies can you name off the top of your head? Just anything to, again, kind of distract and get them out of the traumatic memory and get them back into the present. Doing a body scan can be really helpful. So just kind of having them go through, and always starting with some deep breaths and then going through each part in the body and just kind of checking in with themselves, like, you know, I feel my feet on the floor. How do my feet feel? How do my legs feel? Is there tension in my body? Is there tension like in certain places in my neck? There is, like, maybe I can relax those places. Just kind of, again, just really getting in touch with their bodies and being in the present. Another thing would be having like a grounding or safety object. So again, something like it could be a favorite stuffy that they have, stuffed animal, or a stress ball or fidget toy. I always have fidget toys in my office. Teens really like them too. Sometimes it just makes it easier when you have something in your hands that you can feel when you're talking, especially about hard or painful things. And then, another idea would be something like a blanket, or again, like having that object that kind of like reminds them of home or of a safe person. I know I have one young client that, like, he has a blanket that kind of he calls it mommy blanket. It smells like his mom, and so like wrapping up in that or having that nearby, they can kind of smell, and like that helps him to feel safe. So next, when dealing with a child that is experiencing trauma, using anchoring statements. So again, this has to do with bringing them back to the present, being in the present moment, getting out of the traumatic memory. So you would say things like, I am Marty Tidwell, I am in, and you would say where you are. I'm in my office, or I'm at my home, I feel safe. It is this time on this day. I'm sitting, you know, like if they're in my office, I'm in Miss Marty's office, I'm sitting on her couch. I'm safe. I am, you know, my mom is here, like all of those kind of like anchoring, grounding statements. Another thing would be that is great for grounding is changing the temperature, the body temperature. So, you know, oftentimes when people are upset, they'll splash like cold water on their faces. And the reason for that is because it helps to activate the parasympathetic branch of the nervous system, which helps to kind of reset the body and help the body relax when you're experiencing great periods of stress. So doing something like having the child hold a piece of ice, or running cool water over their hands, splashing water on their face, even like going outside if it's cooler outside and just having like the cool air hit their face, things like that can help to reset as well, and help them to relax. Then the 3-3-3 rule, looking around the environment, naming 3 objects, 3 sounds, moving 3 body parts. other great grounding tools. Okay, so that's it for PTSD. I know that you'll have questions, so certainly we'll talk more about that, I guess, when we get to that part. But I'm going to kind of switch gears now and talk about family therapy interventions, and specifically for children and adolescents with behavioral issues, because I know that this is a big topic and a big issue that often comes up with families that I work with. So different types of behavioral issues that we see in younger children: temper tantrums, angry outbursts, defiance, physical and verbal aggression, hyperactivity, and then kind of social issues, social skill issues with peers. And then some types of behavioral issues that we commonly see with adolescents and teens is, again, defiance, impulsivity, poor decision-making, risk-taking, like reckless driving, drug use, truancy, aggressive behavior, fighting, and then substance use or abuse. So some of these issues are just kind of, developmentally appropriate and kind of growing up adjustment type issues. Sometimes there can be a mental health diagnosis associated with some of these behavioral issues. So some of the mental health disorders commonly seen in children and adolescents with behavioral issues are ADHD, or attention deficit and hyperactivity disorder. ADHD is defined as a neurodevelopmental disorder, which is characterized by a persistent pattern of inattention and or hyperactivity, impulsivity. So there are 3 different types of ADHD. There is the inattentive, primarily inattentive type. So this is just children that have trouble concentrating, paying attention, often have issues with sustaining focus for long periods of time, can sometimes stare off or just have trouble focusing and following along in class and things like that. And then the second one would be primarily impulsive or hyperactive type. So this one is usually kids that have more issues with being disruptive in class, having trouble sitting in their seat, those types of things. Running around, like kind of having trouble sticking with one task and focusing on one task at a time and completing tasks. And then there's a combined type, which is the hyperactive and inattentive type together. Then we have oppositional defiant disorder, or ODD. ODD is defined as a persistent pattern of angry or irritable mood, argumentative or defiant behavior, or vindictiveness towards others. And then there's conduct disorder. This is defined as a persistent pattern of behavior in which the basic rules of others or major age-appropriate societal norms or rules are violated. So these are often kids that, can be involved with the juvenile justice system. With all of these things, early intervention is key. It's really important to identify and start intervening early so that they don't become more severe issues as the child gets older. So the prevalence of behavioral issues in children and adolescents, about 8.9% of children aged 3 to 17 in the US were estimated to have behavioral problems in 2016 to 2019. 9.8% of children ages 3 to 17 in the US were estimated to be diagnosed with ADHD in 2016 to 2019. And then 4 children with behavior problems, more than 1 in 3, also had anxiety and about 1 in 5 also had depression. So there's definitely lots of comorbidity. And again, you know, you think about a child that is having issues with functioning, getting in trouble a lot at school and at home. Oftentimes there are self-esteem issues that come up. There are issues with peers, also be really hard on kids. And so, you know, often there's some depression and anxiety that comes along with this as well. So how do you know when to seek help? How do you know what is developmentally appropriate? And then what is when it's time to seek help? So if the behavior issues get worse over time as the child gets older, at the level of disruption to the child's daily life. So are the behavior issues getting in the way of the child's ability to maintain relationships with peers, participate in extracurricular activities? So are they not able to participate in sports and things like this because of the behavioral issues? And then is it causing significant stress for the family? You know, affecting relationships with siblings, creating parental or marital stress for the parents. Do the behavior issues occur in multiple settings? So are these issues just going on at home or just going on at school? Or are they taking place in multiple different settings? So what are the benefits of family therapy? Well, it can equip parents with tools to better manage behavioral issues in the home, provides more insight into different issues related to family dynamics, gives the family the opportunity to work on issues as they come up in real time with the therapist. So it's different when, you know, as a parent, you're describing the things that happen at home, as opposed to the therapist actually being able to see it take place in real time and be able to address those issues with the parent in real time. And then can address parental stress and work on co-regulation with the parent and the child together. There's different types of family therapy models for children and adolescents with behavioral issues. There's a lot of different ones out there, but I kind of try to, again, focus on more of the evidence-based models. So there's filial therapy, which is a child-centered relationship enhancement therapy, in which the parents and children kind of conduct one-on-one child-centered play therapy sessions with their own children, and they're taught by the play therapist how to do that. There's functional family therapy. This is an intervention program for youth ages 11 to 18 with disruptive or externalizing problems. Brief strategic therapy uses a family systems approach to treat families of youth ages 6 to 18 who have behavioral issues and are at risk of developing behavioral issues like substance abuse, conduct issues, and delinquency. And then PCIT, or parent-child interaction therapy. This is the therapy that I'm gonna talk about primarily because this is the type of therapy that I do with children and families. So PCIT, or parent-child interaction therapy, is an evidence-based treatment for children ages 2.5 to 7 years old with behavioral issues such as physical aggression, defiance, non-compliance, temper tantrums, and hyperactivity. PCIT is broken into 2 different stages. So the first stage is a CDI. It's called CDI, or child-directed intervention. This is the relationship enhancement phase. And then the second phase is PDI, or the parent-directed interaction, and this is the discipline phase. So we start with the relationship enhancement phase that lays the groundwork for then the discipline phase. PCIT is not time-limited treatment, but instead is considered complete after the family has fully mastered all of the skills and the child's behavior is within the normal limits on the behavior rating scale. So we kind of track their behavior over time And once we see like a significant decrease in the problematic behaviors, the parent feels more confident in their discipline techniques and their ability to be able to use the skills that they've learned, and they're at mastery of the skills. Then we kind of consider a family to be kind of graduated. The structure of therapy, so PCIT involves working with the child and parent together using a one-way mirror or live video feed in which the therapist coaches parents through play sessions with the child using a bug in the ear device. The way that I do it is I have like a camera in the room, in the playroom, and then I'm in a different room. I watch over the video feed, and then I coach the parent through a bug in the ear. In addition to once a week coaching sessions with the child and parent together, the parent is expected to practice skills in a short at-home play sessions called special time. This gives the parent the opportunity to keep up with the skills and to keep working on the skills and progressing. And also, again, just really helps to solidify that relationship. The children really enjoy the special time with their parents. And I'm going to speak briefly about the benefits of PCIT. So some of the benefits of PCIT are that it can increase parental confidence and equip parents with tools to be able to better manage their child's problematic behaviors, strengthens the relationship between the child and the caregiver, and cuts down on parental stress, cuts down on the frequency and severity of tantrums and aggressive behaviors, increases pro-social behaviors, so they're learning about sharing, taking turns, cooperating with others, and then the positive outcomes that they learn in PCIT are generalizable to different settings outside of the home, such as school and extracurricular activities and relationships with peers. Okay, so we have some resources here, places where you can find help. We have the PCIT International website if you want to get more information about that. The National Child Traumatic Stress Network has a lot of great resources for children who've experienced trauma. We have the JPHSA website on there, and then Children's Hospital Grief Center, and yeah, this Essentials for Parenting also is a great website that has some great articles as well. So with that being said, that was pretty much all we had. We're happy to take any questions that you have now.
Good afternoon, everyone. I'm Sharon Blackman, and I am the Director of Training at Families Helping Families of Greater New Orleans. Our center is one of 10 nonprofit family resource centers in the statewide Families Helping Families network, covering each region in Louisiana. We provide support to self-advocates and parents of children, youth, and adults with disabilities or special health care needs. And we do this through individual help, information sharing, outreach, and training opportunities. Families Helping Families of Greater New Orleans primarily covers Jefferson Parish and Southeast Louisiana, but we also take calls from all over the state because our center is also the Louisiana Parent Training and Information Center, which is Louisiana's only PTI. A PTI is a federally funded resource for parents of children with disabilities. Each state has at least one PTI, depending on the state's population. And PTIs are funded through Part D of IDEA, the Individuals with Disabilities Education Act. And PTIs have several purposes. They teach parents of children with disabilities about their educational rights under IDEA, under Section 504 of the Rehabilitation Act, and also under Americans with Disabilities Act. PTIs provide parents with information about their child's disability. They teach youth and young adults about self-determination and self-advocacy, and they provide resources in the community as needed. So Families Helping Families of Greater New Orleans also does all those things. A lot of people ask about how we're funded since all of our services are free. We do have private and corporate donors as well as funding through various foundations, but our biggest funders include the U.S. Department of Education and the Louisiana Department of Education, who together provide about 75% of our funding. We also get monies from Jefferson Parish Human Services Authority, or JPHSA, and the Louisiana Department of Health, and then under the Department of Health, the Bureau of Family Health as well. Besides funders, we have community partners. Our community partners are organizations who don't provide funding, but who are involved in the lives of children or adults with disabilities. And our community partners include the other 9 Families Helping Families centers around the state, disability-specific support groups like the Down Syndrome Association, the Spina Bifida Association, Autism Society, and others. Also, school districts are community partners. The local human services authorities and districts, like in Jefferson Parish, JPHSA. Also, the LSU Human Development Center and other businesses and groups that promote positive outcomes for people with disabilities. There are 4 primary programs of Families Helping Families of Greater New Orleans, and these are the 4 pieces that our center provides. And those are, first, information, resources, and outreach. The second is education and training. The third is youth. And the fourth is peer-to-peer support. And I'll say a little bit now about each of those programs. The first program, as I said, is providing information, resources, and outreach to families who call on us. We publish a quarterly digital magazine called Exceptional Times, which is a wonderful resource that includes articles of interest as well as information on current and upcoming events and activities. We have a website, which is FHFOFGNO.org, and it contains information and resources on numerous topics related to disability. We're active on social media, Facebook, Twitter, Instagram, YouTube, etc. We attend and host local outreach events, resource fairs, or school events where community partners are invited. We provide disability-specific information for families upon request, and we also send out a weekly email with information and reminders of upcoming events, as well as our new resources or activities that our families may need to know. And you can go on our website to add yourself to that list if you'd like. Our second program is education and training. Our philosophy at Families Helping Families is this: give a man a fish and he'll eat for a day. Teach a man to fish and he'll eat for a lifetime. We want to teach our self-advocates and our families about their rights under the various disability laws and to help them learn to advocate for themselves. We offer over 100 training opportunities every year, both in person and online, on every imaginable disability and special education topic. We keep links to archive trainings on our website as well. We can offer trainings in Spanish, and some of our archive trainings on the website are in Spanish. And if a parent needs an individual training, we can even do that. Some of the education-related training webinars that we offer include the ones that you see on the screen: Louisiana's dispute resolution options. We do parent rights and special education, and these 2 webinars are offered every month. We have a training on IEPs versus 504 plans. We teach about accommodations and modifications, how to get the most from related services, and anti-discrimination laws in students with disabilities. We also offer trainings on the transition from youth to adulthood, and at least twice a year, we host an attorney or a financial advisor who talks about special needs trusts or continuing tutorships. And the third Families Helping Families program is youth. Our newly formed and growing youth program focuses on providing resources for youth and young adults, as well as giving them safe opportunities for social growth. We host online young adult chats, and we also provide peer support and assistance with transition-related issues. Our fourth program peer-to-peer support is what makes Families Helping Families special. All of our staff are either adults with disabilities or parents or close family members of children with disabilities. We provide support to other parents because we've been there. We know what a gut punch that official diagnosis was. We know how hard it is to get the right supports in school, and we know the difficulty of finding doctors and dentists for our young adults with disabilities when they age out of pediatrics. We reach out to families by phone, in person, through social media, and we even find ourselves sometimes helping with school meetings. We help other families because we are passionate about sharing our experiences and keeping others from finding themselves in the same sinking boat that we found ourselves in earlier. We at Families Helping Families have high expectations for people with disabilities, and that includes our own children as well as others. We expect them to be seen for who they are and not for their disability. We expect them to be treated fairly and equitably. We expect them to be included in every aspect of society with their peers. We expect them to be assumed competent. And we expect them to grow up to be successful adults and contributing members of society, whatever that may look like. Please feel free to contact us, like and follow us on social media, or check out our website. And I'll be here until the end of the presentation to answer any questions that you may have about Families Helping Families.
Thank you all so much for all of the great information today. I know that it's so helpful for people to know not only, well, they're in the midst of things. So it's so helpful for them to hear from you about what the resources are and about ways that they can work with their young people. Please, if you're attending the webinar and you have any questions, please feel free to put those in the chat. We'd love to hear from you. Hi, Marty. Thanks for joining.
Oh, we've got Sharon and Todd here too. Fantastic. Before I have, as questions come in the chat, I have a couple myself. We have been hearing two issues. One, we've been hearing that there's really been a dichotomy or a separation with what parents are telling children versus how parents are reacting to that. Are y'all seeing that in the schools at all, or in your dealings with youth? I know it's kind of a different population, but you deal with a lot of mental health stressors also.
Repeat the question.
Well, the question is that we're hearing that that students and that young people are overcoming a lot of the stigma of mental health, but that when they approach parents feeling like not armed with the information to deal with it, or don't know where the resources are, maybe aren't responsive to the cries for help. Are y'all seeing that at all?
I think that they, with the successive generation that'll come, it is getting more, it's easier to be acknowledged. It's easier to be identified, and it appears easier for the kids to be able to say, hey, here's what I'm feeling or what I'm going through, or at least approach that subject. The parents can still be hesitant and have some older ideas of, especially around like, medication, or just the idea, not necessarily equating that what can be happening in the mind is really no different than if their child broke their arm.
Right.
Yeah. Marty?
Yeah. Marty, do you have thoughts about that too?
Yeah,
I saw you
I
shaking
agree.
your head.
Yeah, I agree. I think that, with older generations sometimes, and even, you know, thinking back to when I was growing up and stuff, mental health was not something that was talked about as much. And I feel like, you know, yes, as children are kind of becoming more, that stigma is breaking down in terms of with them and with their peers, it isn't necessarily with parents, grandparents, older generations. And so that can be hard sometimes. And I think that's where it's really important, the push around like social emotional learning in schools, and having, you know, competent counselors that can kind of help work as a liaison and kind of help, you know, help kind of talk with the parent and help get that child connected to resources.
There still is a stigma associated with medication in particular, or just acknowledging, and like Todd said, you know, if a child has diabetes and they need insulin, the parent is going to give them that, you know, but it's just somehow still seems different, and it's still stigmatized to take a medication for a mental health issue. And you know, there is that generation gap, and a lot of times too, parents have a little bit of doctor anxiety that goes along with that. And when they're talking to a physician, and the physician say puts their child on a medication, they're not given enough information at that point to know that if this medication doesn't work for this child, there are other options. You know, so that's another one of the things. My son has seizures, so we deal with that with seizure medications. I don't want him to be knocked out. You know, I don't want him to be incapacitated or groggy and really lethargic all the time. And it's the same thing with some of these mental health type medications, and parents don't realize that there are other options, and that they need to have a good open line of communication with their physician about that.
Yeah, it's really an education gap there. Like, we're doing great on the younger generation, and certainly social media is reinforcing that. But the parents maybe are not hearing those lessons. So my other question is, we have done a couple of these webinars talking about the dual diagnosis of intellectual or disability, and then mental health. And because of the way that our mental health block grant funding comes down, or our block grant funding comes down, we know that a lot of the public infrastructure has not combined that, and I think they're getting better, but historically people were seen in silos. They were seen and those two sides did not communicate. Are you seeing an evolution there, particularly with talking about public insurance?
Marti?
Not as much as there should be, I don't think, is the short answer.
I think just yesterday I was having this conversation with a group of people about how most people acknowledge, and if you watch the news, again, it's all mental health, mental health, mental health, and which is good. What it does not feel like has caught up and balanced out is actually putting the resources in place, and really the direct resources, because what we know is that the number one thing that can really help a child is connection. But in order to have those connections, you also want to have consistency, and you want to be able to have some time with them. And unfortunately, again, I haven't seen that has caught up yet. It looks good on paper, and it looks good in a 15-second news item, but it's not acknowledging, you know, really the resources that it takes to really address the specific needs, like we talked about today, of depression, anxiety, and post-traumatic stress disorder. It's not like anybody can just come in and do that to provide quality mental health services for those kids and therapeutic services for those kids. And so hopefully that will shift and change, but it doesn't seem quite there yet.
Yes, I mean, with 67% of our population is rural based, and we are in the bottom third for access to care. Yeah, we've got a long way to go in Louisiana, and some hurdles to climb. And I mean, it is challenging for resources to get resources out when you've got that large a percentage of your population in a rural area. Sharon, I saw you shaking your head. I know you have firsthand experience or have walked people through trying to get that combined care for their family member. Any thoughts there about where we're going there, or if you're seeing improvements? And
Well, I mean, as far as insurance, our family deals with private insurance. I don't know
Sure.
the difference between, say, Medicaid and what they will cover as far as counseling services go, as opposed to private insurance. We had just started looking into counseling for my daughter, and we're looking at that, and we never needed to follow through. Thankfully, some things were resolved, but there is still it's still difficult to get insurance to pay. And then what we were finding was that when I was looking for counselors, I called probably half a dozen centers, and there was a 4 or 6 month waiting list. And so I was like, but I need help now. So
Yeah,
when you do have funding, or you find funding, then finding a provider is yet another hurdle. I do have my daughter is in 5th grade now, and since she started school in the 1st grade, the counselors do one of their enrichment classes is actually with the school counselor, and they do different things, activities where they can talk about their feelings, and they go through anger management and different kinds of things that we didn't go through that when I was in school. So and her classes also, she was in 1st grade when we shut down for COVID, so her class was one of the classes that has grown up so far with COVID, as still being in the picture, and that still causes some anxiety. And anytime we hear something on the news about some other bug, it kind of everybody gets a little post-traumatic stress going on, but
indeed.
yeah, there's still issues with making the two things come together, having the providers and having the pay, to be able to take advantage of those services.
Sure, sure. Well, we don't have any questions. I don't see that any have come in. Do y'all have some final thoughts or things that you want to share? And I know that you all put your information in there and have invited people to contact you if they have further questions. It may be a personal question that people don't want to answer ask in this forum, and we certainly respect that. But any closing thoughts from all of y'all would be great.
I know that I had mentioned this in the presentation, but I'll say again, because I think it's important that, if there are things that you're concerned about, early intervention is key. So reach out, and, that's why we included like those different resources. I know that it is sometimes hard to get services and get services right away, and there are waiting lists and things like that. But if you have concerns, I would say, go ahead and reach out to a provider, and just kind of try to get that process started.
Great advice. I mean, we have to do it on every front, right? We have to be our own health advocates. We have to be health advocates for our children, and that we just persistence is unfortunately required in the system that we are currently finding ourselves. So, thank you, Marty, for reiterating that point, especially on early intervention. We see the studies, the overwhelming research about why that's so important. Todd?
Yeah, I would say it's really important to keep in mind that, especially for parents, that the mental health of their children equates with educational stability and educational success as well. And if something comes up, whether it is a trauma, or even if it is potentially some like possibly genetic depression or something, that these issues can be worked through, and they can be addressed and they can be dealt with. It is not the stopping of anything. So that's what I would say is, yeah.
Yeah, I love that. Mental health is health. We say it all the time around our office. It really is. And I've been doing a lot of trainings for youth mental health first aid. And the message there is that there is healing, that there is recovery, and that there is life. And mental health at the end of those journeys is possible, or in the midst of those journeys. You don't really ever end them. Darren, your thoughts, closing thoughts?
I really appreciate the presentation as well. I've heard Todd speak before. He did a webinar for us. Marty, it's very nice to meet you. So I really appreciate the information that was shared. I would also say it is a difficult journey sometimes, and especially if you have a child with a dual diagnosis of a developmental or intellectual disability as well as a mental health issue. Please call one of your local Family Help and Family Center. Our center is in Jefferson Parish, and we also, as I said in my part of the presentation, we also serve the whole state as Louisiana's Parent Training and Information Center. So if you have education issues, we can help you. If you need services in school, please call on us. If you're elsewhere in the state, you have a local Family Help and Family Center, and we are all here to help. And we're here every day, and we're free, so you don't have to worry about insurance to get with us. But please do call on somebody and get some assistance in getting the services that you need for your child.
Well, Sharon, we know that y'all just do wonderful work there, and that you're such a gift to so many across our state who find their ways to your door through various and sundry means, sometimes through us, sometimes through others, a lot of times through others. So we're grateful. And Todd and Marty, we're so thankful for your time and your expertise. And we appreciate everybody who attended today. And this was recorded and give us about a week, and it'll be up on our website. So if there are things that you want to go back and listen to, both Todd and Marty had lots of information to share. So give you a second to unpack that. Thank you again for joining us. I'm Stephanie Francis at the Louisiana Mental Health Association, and have a great day. Thanks.
Thank you.
Bye.